Great. So I think I'll start with the introduction. More people have joined now, so we can get going. Welcome to this morning's Internal Medicine Academic Meeting. It's being hosted by the Division of Medical Oncology. And certainly, I think more and more cancer is becoming a problem or a emerging concern. I think it's very much on the agenda of our Department of Health. As non-communicable diseases become the forefront of where we see our, in inverted commas, pandemics going. So surely infectious diseases have been at the forefront, but as we do better, hopefully from an infectious disease point of view, we will find that an aging population, more and more cancers become diagnosed, more and more cancers are required to be treated. And as such, it's a very important division. 1 in 4 people in their lifetime will develop a cancer. So as such, I'm very happy to be able to introduce this morning to present on malignant melanoma, and his title is From the Middle Ages to Mutations. It's Dr. Peter Anastasiades. He is a fellow in the Division of Medical Oncology, having joined us this year. Dr. Anastasiades is no stranger to medical oncology at Charlotte Macheke. He has been in our division first as a community service officer, fresh out of his internship. He always at that point indicated an interest in doing medical oncology. He then joined the Steve Biko Medical Oncology Division as a medical officer for a few years before going and doing his internal medicine time, and has now returned back to medical oncology. So he's done his MMed in medical oncology. He is very much interested and keen, and has a very keen interest in research. So Peter, I'll hand over to you now to present on malignant melanoma. Thank you.
Thank you, Prof. Morning, everyone. Can everyone hear me?
Yes, we can. Thank you.
All right. So I'm going to start. So we're going to be looking at melanoma through time and where we are currently in the management of melanoma. So prior to the 21st century, metastatic melanoma was seen as a malignancy with a dismal prognosis. For us as doctors, if you saw a patient and they had melanoma that had metastasized, we all inside had that feeling of doom and gloom. But then things in the second decade of the 21st century, things started to change, because in 2011, it was a landmark year for metastatic melanoma therapy. And that's when there was a buzz around melanoma research and clinical trials. So history of melanoma. So melanoma was first described by Hippocrates in the 5th century BC, was found in the literature as old as then, and we also have evidence of human remains which were found in South America of radiocarbon dated mummies that are over 2,400 BC years old, showing evidence of melanoma. And so it shows that melanoma has been with us probably since humans have been around. So the Scottish surgeon John Hunter worked at St. George's Hospital in London and is credited with the first surgical removal of a melanoma in medical literature. And then in 1858, Oliver Pemberton, he put a case series together of 60 patients between 1820 and 1857, describing the clinical characteristics, the sites of the metastases, and those specimens can be found in the London Pathology Museum if any of you ever go to London and want to have a look. They even have the first paper. It's in a glass case. And then interest in the surgical management of melanoma gained momentum in the 19th century, and has since then always been an interest in how can we manage melanoma. And it needs to be remembered that early stage melanoma, namely stage 1, with no lymph nodes, stage 2 with adequate resection margins. These are curable malignancies, and 95 to 98% of the patients are still alive after 5 years. The problem starts when you with the stage 3 and 4. So in 1917, Alexander Breslow, as a pathologist in London, he observed that prognosis of cutaneous melanoma appeared to be a function of both the tumor size and the level of invasion, with tumor thickness the most significant measure of size. And then the Breslow's thickness was defined as the total vertical depth of the melanoma from the granular layer of the epidermis to the area of deepest penetration in the skin. And then Clark's level 2 lesions and lesions less than 0.76 millimeter in maximal thickness were noted to be associated with a more favorable prognosis. These criteria helped in stratifying patients to have or not have prophylactic lymph node dissections, or as now we call them, sentinel lymph node biopsies. So the work of Clark and Breslow is still very relevant today, and as oncologists, we use it every day when we see a melanoma patient, when we use the AJCC version 8 melanoma staging system. So this curve's from the NCCN guidelines. It basically shows melanoma survival curves, and it shows you that stage 4 being the black line and stage 3D being the green line have the poorest outcome, whereas you can see in the early stages, stage 1, 2, and even stage 3A have a favorable outcome, where you see after 60 months of stage 1, 96% of the patients are alive. And then with stage 1B, 94% of the patients are still alive. Whereas if you were to compare to stage 4, only 23.4% of the patients are alive. And this is important because the next slide, after this slide, I'm going to be discussing a timeline of what we've had to treat melanoma. And it's actually surprised me when I saw it. So we have different types of melanoma, the main 4 types being nodular melanoma, superficial spreading melanoma, acral lentiginous melanoma. Acral lentiginous melanoma is usually found on the peripheries of the lower limbs mostly, and it's mostly it's mostly found in people that are exposed to sun, so in Africa and as well as the Mediterranean belt and South Asia and the Middle East and Far East. So this is a very important slide. So as you can see, I mean, Hippocrates first described first melanoma in 5000 BC. And then for metastatic melanoma, we only had something that showed some form of benefit in 1975. And we're now in 2022. And to think that over that time, that's when everything for melanoma has come out for the metastatic melanoma, advanced stage 3 and stage 4 melanoma. And as I go on through the slideshow, we'll be able to see what we do have, side effects and how we use them, and what's the response rates to these drugs. All right. So nowadays, if you were to have a patient with a melanoma, that melanoma would be excised and appropriate margins and sentinel lymph node dissection done if needed. Of course, the patient would be staged with a PET scan or a CT scan, and then the melanoma would be tested for mutations. Mutations that are important in melanoma are the BRAF mutation, the NRAS mutation, the NF1 mutation, the KIT mutation, and the MEK mutation. Why these are important? Because we actually have drugs that can act on the mutations and slow down cancer growth. So there again, our table. And in 2011, the first BRAF inhibitor was started trials, and then it was officially made available by the FDA in 2011. But prior to that, in 2011, we have the first immunotherapy that became available for melanoma, and it did change, as we'll see further when we're showing tables. I'm going to show you a case study. So I have a 50-year-old male Caucasian. He's got a red hair phenotype. He works in the sun a lot, and he didn't wear hats or sunscreen. He's a geologist, so he's in the fields, and he had prolonged sun exposure since he was a child and till the day he was diagnosed. So he presented to his GP with a pruritic hyperpigmented lesion on his right posterior hairline of the scalp, and it was ulcerated. And on further examination of the epidermis, there was multiple seborrheic keratosis, compound nevi, squamous cell carcinoma of the skin, and basal cell carcinoma. So they decided to do a biopsy. So an incision biopsy was done of the lesion, which is not ideal. Always remember with melanoma, you rather get someone who, if you're thinking it's a melanoma, send either to a surgeon, plastic surgeon, or a good general surgeon, because they know there needs to be margins and what else they need to do as well. For example, a sentinel lymph node biopsy. So an incision biopsy was done, and the lesion measured 2.6 by 1.4 centimeters. It was hyperpigmented, and the diagnosis was a malignant melanoma, Clark level 5, Breslow thickness of 6.5 millimeters with involved surgical margins. And if you look at the Clark and Breslow staging, it's actually, this is a poor prognostic marker. At the time, there was no ulceration and no lymphovascular invasion. So 6 days later, the patient was referred by his general practitioner to a general surgeon, and he underwent a wide local excision of the lesion and a sentinel lymph node biopsy, followed by a block dissection of the posterior triangle of the neck. And I'll explain to you shortly why they did the posterior block dissection. The histology of the dissection was a wide local excision and a sentinel lymph node biopsy, and it showed 8 by 7.6 millimeter skinny lips, which contained the malignant melanoma. And our tumor depth was 7 millimeters, and the tumor was 3 millimeters from the deep resection margins. Ulceration was present, as I initially mentioned, and 5 out of the 7 nodes that were removed show evidence of metastatic melanoma. So his block dissection findings, there was right sternocleidomastoid muscle with overlying skin and 5 attached lymph nodes. The sections revealed multiple brown-black nodules within the connective tissue, which was in keeping with a metastatic melanoma. All of the 5 nodes showed involvement by metastatic melanoma, 2 of which are completely replaced by malignant melanoma. Lymphovascular invasion was identified, as well as extracapsular avascular infiltration. Posterior neck dissection showed fibrofatty tissue with 7 lymph nodes, which showed no evidence of metastatic melanoma. So our assessment is that we have a 50-year-old male that's of a red hair phenotype. He's got an ECOG performance status of 1, no comorbidities, with newly diagnosed metastatic malignant melanoma, T4B N3M1A. So now, what do you do with this patient? So the patient was referred to us, and then what we did was we did a PET scan. And if you can look at the images, the first 2 on your left-hand side, on the top, on the first image in the top, if you look at that yellow focus there, that's the lymph node that showed that there was disease. And then if you look at the second picture, I know it's a bit difficult, but if you look on the left-hand side and a little bit posteriorly, you see that well-circumscribed lymph node, again, picking up the FDG, showing that it's active disease. We'll come back to the image on the right, just that's for now. So what happened was, and in this was in 2012, the patient was then seen, he received 2 cycles of DTIC, which is dacarbazine, which is standard of care for us at that time for melanoma. And I mean, it was standard of care since 1975, but the response rates to DTIC were not prolonged, they were short-lived. So when we were starting patients on DTIC, we knew there wasn't much more we could do after that. All right. So he had 2 cycles of his DTIC, developed alopecia and a little bit of nausea and vomiting, but otherwise was okay. And then they repeated the scan, and the scan showed he had disease progression with the right posterior triangle lymphadenopathy increasing in size. So at the time, we were able to have an extended access program to Ipilimumab, because if you remember my timeline, Ipilimumab was FDA approved in 2011, and the company was being able to assist both the public hospitals and private hospitals alike with an access program to Ipilimumab. So he was started on Ipilimumab, and he had 2 cycles at 3 milligrams per kilogram IV every 3 weeks. And the patient then presented with pleuritic chest pain and dyspnea. And the CT showed evidence of metastases with lung, pleural, mediastinal metastases, and they were all called disease progression by the doctor. It also should be noted that the tumors patient was BRAF positive. So now back to the image on the right, the baseline image is July 2012. So this is the PET CT when they confirmed PD after the query PD after 2 cycles of Ipilimumab. And as you can see, the FDG uptake showing query lung mets, there's a query malignant pleural effusion. So just think about this, because initially in those days, this was accepted as disease progression. But as the studies with Ipilimumab and the immunotherapies went along, we actually became aware of a phenomenon known as the flare phenomenon. I just want you to keep this in mind for when we close off. Okay, so as I said, so then we sent the patient for tissue for BRAF mutational analysis, and it came back positive. So at the time, as you know, vemurafenib had just been FDA approved, and there were clinical trials being done on vemurafenib, and the patient was eligible for a clinical trial. So he was enrolled onto one of Roche's open label multi-center studies on the 27th of June 2012. And we started the patient on vemurafenib 960 milligrams twice a day, and we continued it. And the study closed on the 18th of January 2015, which is 7 years ago. And the patient continued his vemurafenib courtesy of Roche and the Access program. And he currently still is around with us and is still on vemurafenib with no evidence of disease. But you don't need to believe me, I'll show you the images. So the patient didn't have any complications in the initial years on vemurafenib. This was his first PET CT after trial had closed. And as you can see in the neck, that lesion that was there isn't there. And the lesions that were in the lung are not there. And that pleural effusion is not there. So you could say now, was it the vemurafenib that did this? Or was it the Ipilimumab? And the truth is we don't know. Because with Ipilimumab and the immunomodulating agents, as I said, patients do get flares. And if we look at the literature now, and if you were to show this to a group of oncologists, they would probably be in agreement that that most likely was a flare. All right. But anyway, the patient's still on his vemurafenib and he's doing well. So I'm just going to do a review of the radiological follow-up with him. So he had his first CT after his dose of Ipilimumab in July 2012, which showed a left pleural effusion, lung metastases, and a pathological mediastinal nodes, as well as pathological lymph nodes and soft tissue metastases of the neck. And then in September, the left pleural effusion was smaller, the lung metastases had decreased in size, his mediastinal nodes had decreased in size, and his soft tissue metastases had remained unchanged. And now remember, he's on the vemurafenib. And then in 2013, his pleural effusion resolved. There was no evidence of lung metastases. There was no pathological mediastinal lymph nodes or soft tissue metastases. And the metastases in the neck had remained unchanged. And then in April of 2014, the pleural effusions once again still resolved, no evidence of lung mets. The mediastinal nodes had decreased in size, and the soft tissue metastases in the neck had also decreased in size. Then a year later in July, his PET-CT showed no increased uptake, so he had a complete metabolic response. And then again in 2016, his yearly PET showed complete metabolic response. And then it's currently now, his last PET was done in January of this year, and this patient is still in complete remission. He does have some side effects from the vemurafenib, but when I speak about the BRAF inhibitor side effects, I'll elaborate more on that. So in summary, our patient was a 50-year-old male with malignant melanoma stage 4, and he was diagnosed in 2012. I just need to emphasize that. He had 2 cycles of what was available to us at the time, DTIC, and then because of the extended access program, we were able to put him on Ipilimumab, and what he had was most likely a flare. And then afterwards, they thought he had disease progression. We were able to put him on a clinical trial of vemurafenib, and that's why clinical trials are so important. They give our patients access to drugs that we don't normally have, and for many patients, it's very important because it's their last chance of getting something that will actually work. So like I said, as of March, he has no evidence of disease, and it's 7 years later and he's still in remission. But is this the case for every patient? Let's look at the data now and the evidence, and then I'll take it further. All right, so as I said, in 2010, the first article came out on Ipilimumab in metastatic melanoma, and it was showed that there was increased progression-free survival as well as overall survival. But we wanted to know, were these responses durable? So, and during that second decade of the 21st centuries, that's where I would call it the golden age of immunotherapy, because we started having more and more immunotherapies as well as BRAF and MEK inhibitors for melanoma. So this article showed a progression-free survival and overall survival, but the response rate after 5 years, they say only plus minus stays, and the articles vary, but majority of them show that only 20 to 30% of the patients were still in remission, whereas the others had disease progression. And then they did another study showing Ipilimumab with what we have, dacarbazine, and it showed that the arm with Ipi alone did just as well as Ipilimumab and dacarbazine, and then Ipilimumab was registered as a single agent for metastatic melanoma. And then came the trials with the BRAF and the MEK inhibitors. So initially, I just want to say that initially we gave BRAF inhibitors alone. And the first one that they studied and came out and was approved by the FDA was dabrafenib. So, and then it was shown that dabrafenib does give a survival advantage, but the melanomas develop resistance to the BRAF inhibitor, the dabrafenib. So then they added a MEK inhibitor, which in this case, it was trametinib. And the trametinib slowed down the resistance, but I'll discuss the mechanisms shortly with a diagram. And then we started using combined BRAF and MEK inhibition versus BRAF inhibition alone, which I had just spoken about, and here's just another article. And then here's another one where it shows there's improved survival, overall survival on both a BRAF inhibitor and a MEK inhibitor. Then what happened was the oncologists said, but if it's so good in the metastatic setting, what happens if we were to give it to the patients that are on stage 3 that would probably progress to being metastatic? And they found that it worked as well. All right. And then this is a very important study. It's the KEYNOTE-1 study. So after Ipilimumab, there were multiple PD-L1 inhibitors released, those being pembrolizumab, nivolumab, avelumab, and as we go on, I'll tell you about more. But the 5-year survival outcomes showed that there was progression-free survival and there was overall survival, but it wasn't lasting. Out of all the patients, between 26 to 30% only had survived by 5 years post their diagnosis. So now we're going to look at the combined BRAF inhibitors and MEK inhibition melanoma trials, and what does the data show? So the first study we're looking at is the dabrafenib and trametinib study versus dabrafenib alone. Now dabrafenib is the BRAF inhibitor. As I said, initially they were given alone, and then afterwards they were given with a MEK inhibitor, which is trametinib. So our overall response rate initially was 76% versus 54% on the dabrafenib alone, with a p value of 0.03, with a median duration of 10.5 versus 5.6 months, and median progression-free survival of 9.4 versus 5.8, with a hazard ratio of 0.39, with a 95% confidence interval, and our p value being less than 0.001. So this study, the median was not reached at the time of this analysis because the patients that were on the BRAF inhibitor, dabrafenib, and the MEK inhibitor, trametinib, they all crossed over. The monotherapy arm crossed over to the dual therapy arm. Okay, and then we look at the second study, the COMBI-D study, where it was dabrafenib and trametinib versus dabrafenib, and it was done by Long. So our overall response rates here were 67% versus 51%, with our p-value being statistically significant at 0.002. And our median duration of response was 92 versus 10.12 months. And then our median progression-free survival was 11 versus 8.8, with a hazard ratio of 0.67, it's a 95% confidence interval, and our p-value being 0.00004. And then overall survival, 25.1 versus 18.7, 25.1 in the dabrafenib and trametinib arm. And the overall response was 74% for the dual arm versus 68% in the single arm of dabrafenib. And then at two-year overall survival, 51% was still alive, and then versus the 42% on the single agent dabrafenib. Okay, then we went on, then they did the COMBI-V study in 2015 by Robert et al., which they tested dabrafenib with dabrafenib, a BRAF inhibitor with trametinib, MEK inhibitor, versus vemurafenib, which is another a BRAF inhibitor, and actually the first BRAF inhibitor that was available on the market. Overall response rate was of 64% with the combinations versus 51% in the single arm of vemurafenib, with a p interval of p value of less than 0.001. And then our median duration of response was 13.8 versus 7.5 months. Okay, so then our median progression-free survival was for the combination 11.4 months versus 7.3 months for vemurafenib alone, with our p-value being less than 0.001. And then if you look here, the 1-year overall survival of 72% for 2 drugs. I mean, if you were to think about this before the study, 10 years before the study, patients with malignant melanoma stage 4 did not, by 1 year, survival was less than 25% versus 65% here on the vemurafenib arm, and the p interval once again significant at 0.005. They then did the vemurafenib and cobimetinib arm, with vemurafenib is again a BRAF inhibitor and cobimetinib a MEK inhibitor. So they had 87% of a response rate in patients who had never had a BRAF inhibitor. That was one of the exclusion points for the study. And then the median progression-free survival was 37.1, but they didn't give us an overall survival, and they didn't give us a median duration of response. And hopefully there's going to be a follow-up article to this one, and we'll be able to see. And then we have the COBRAM study, where it was vemurafenib and cobimetinib versus vemurafenib alone, and it was done by Larkin in 2014. So at 7.3 months median follow-up, 68% overall survival versus 45, with a p-value of less than 0.0001. And then at our median duration of response at 14.2 months, it was 13 versus 9.2. And our median progression-free survival at 7.3 months was 9.9 versus 6.2, with our hazard ratio being 0.51 and our p-value being less than 0.0001. And then at 14.2 months, our overall survival was 22.3 versus 17.4. All right. And then at 2 years, we had overall survival of 48.3 versus 38 of the single arm vemurafenib. So yes, these drugs are good, they do work, but the survival, how long does it last? And it depends on the patients. The patient that I presented in the case study is really lucky in that he's now 7 years down the line and he's still in remission. But these drugs, as all drugs do, they have side effects. And one of the side effects of the BRAF inhibitors is if they are prone to developing squamous cell carcinomas. So this patient, our patient in the case study, was seen by the dermatologists every 6 months and followed very closely. And because last year he developed 3 squamous cell carcinomas, and they were removed, and he had radiation, and they're okay. But it's just, you've got to remember, as with every drug, you watch for the side effects, and this one is an important side effect because it's a malignancy. So yeah, and then comes then you'd say, but do we continue the drug or stop the drug? Because he hasn't got any active disease. Because there's been cases in the literature where they've actually stopped the drugs and the patients don't go into disease progression. And there's also been cases in the literature where they've been given a CTLA-4 inhibitors, Ipilimumab. They received 4 cycles. And then because it was the early days of the trials with Ipilimumab, they initially thought that flare was disease progression. And so they stopped treating the patients. And you can see them 7 to 10 years later. Some of the patients on the trial are still alive, but it's not to say that they aren't, but those are the scarce few. They're the exception to the rule. So what are our current guidelines for advanced melanoma? And the NCC guidelines state that all patients, if possible, should be involved in a trial as gold standard care. And I agree with this because the reason being, if we have access to clinical trials, you'll be giving the patient what is known by NCCN as gold standard treatment, what is basically the best that we have available versus the experimental drug, or the experimental drug and the gold standard versus the gold standard alone. And it gives our patients a fighting chance. There's a few articles, and it says that less than 5% of all patients with cancer are able to get onto a trial, which is, for us, it's scary, because that's why I'm one of those, if there is a trial, I try and put a patient on. If they can meet the inclusion criteria and they have a good performance status, then by all means, let's try to get them onto a trial, because with some of our malignancies, melanoma being one of them, it's their only fighting chance. Okay, and then they also speak about adjuvant therapy for our stage 3A to D, which I showed you the articles, that now we use it, and you have the patients don't relapse after receiving 2 years of immunotherapy. And then remember, we can use it for stage 4 metastatic disease and still get an overall survival and progression-free survival. So our drugs used in advanced melanoma are our cytotoxics. So the poster child for cytotoxics for melanoma is DTRC or dacarbazine, but you can use, there are others, but their outcome and response to treatment is just about the same as DTRC. So it's less than 12% response rates. So DTRC is one of them. Another combination you can use is carboplatin and Taxol. It's just with that particular regimen, you need to watch out for neuropathy, because the carboplatin and especially the paclitaxel can cause severe neuropathy. So at every visit, you monitor your patients. And then we look at the BRAF inhibitors and MEK inhibitors, which have now become standard of care. The CTLA-4 inhibitors, Ipilimumab, it's not nowadays what the patient had on this trial, which was vemurafenib, and prior to that is Ipilimumab, and prior to that he had Ipilimumab. That's not standard of care anymore. Now you'd give vemurafenib with a MEK inhibitor, and the Ipilimumab you would leave for later if he had disease progression. And you could give it either alone, or you could give it with a PD-1 inhibitor such as nivolumab with the Ipilimumab, or we can go on to what is now used in the first-line setting metastatic, which is pembrolizumab here in South Africa. But there are a multitude of PD-1 inhibitors, right? And the PD-1 inhibitors are both used in the metastatic setting and the adjuvant setting. So in our adjuvant setting, the stages 3A, who are sentinel lymph node negative, and stage 3B to D, that are sentinel lymph node positive. What are our options? And here our options are dabrafenib and trametinib, who carry the BRAF mutation, obviously. And then, so you give the tablets on day 1 to 28, twice a day. And you watch for side effects, okay? You need to watch their liver functions. You need to watch for dermal toxicities. Unfortunately, these drugs do cause a lot of dermal toxicities, and you need to have a dermatologist involved. And if it's a grade 3 or 4 toxicity, you hold the drug until it improves, okay? And sometimes even with the grade 4 toxicity, and you don't reintroduce the drug. Then another option is the PD-1 inhibitor nivolumab, which is category 1 evidence. So you'd give the nivolumab for 240 milligrams IV over 30 minutes and repeat cycle every 2 weeks for a year. Or the other option is giving nivolumab for 80 milligrams IV over 30 minutes, and you repeat every 4 weeks for a year. The second one being a more time acceptable option. And then once again, you can use pembrolizumab, which is category 1. So there you would give pembrolizumab 200 milligrams IV over 30 minutes and repeat cycle every 3 weeks for a year. Or what you can do is, because of patients now, we're wanting them to have better quality of life and not wanting to have them in the chemotherapy lounge all the time, you can rather go 6 weekly for once a year. And then in the metastatic setting, you can give our pembrolizumab, once again, that at 200 milligrams every 30 minutes, and you give it every 3 weeks, or if they're worried about time and being spent in the oncologist's office, you can give 400 milligrams every 6 weeks for 1 year. All right. And the other options are nivolumab, and then another option is our BRAF and MEK inhibitors, vemurafenib and cobimetinib. Then we have, once again, so if the patient has had previous pembro or nivo, then you can use ipilimumab alone. And with ipilimumab, if you see the dosing is different, it's according to body surface area, it's 3 milligrams per kilograms over 90 minutes. And you repeat the cycle every 3 weeks for 4 cycles to assess response. And now we have what we have called oncoviruses, and it's the intralesional telomerase. And this has shown some benefit. There's a lot of studies with a lot of oncogenic viruses, oncolytic viruses, my apologies, available and being used and assessed in clinical trials now. So our mechanisms of action, I'm not going to bore you with too much details. I just wanted to give you a basic understanding of how these immunotherapies work. Okay, so our APC is an antigen presenting cell, and then it's our T cell. So what happens is this activation is initiated by binding of B7 molecules on the antigen presenting cells to CD28 receptors on the T cells. And then the T cell there's inhibition results from CTLA4 expression on the T cell surfaces, where it competes with the CD28 for binding to B7 on the antigen presenting cells. So then there's potentiation of T cell proliferation achieved by CTLA4 inhibition using Ipilimumab. Okay, and as you can see, there's T cell proliferation, and there's the immunotherapy Ipilimumab, and it's bound to the CTLA4, and that's how it works. Right, now moving forward to the BRAF inhibitors and MEK inhibitors mechanism of action. So as you can see, here's a healthy cell in plane A, and then next to it, it's plane B, and it shows BRAF. Okay, so if the tumor is BRAF V600 mutated positive, you can use a BRAF and a MEK inhibitor. So it stops the cells from proliferating and dividing and surviving. But we noticed that by using a BRAF inhibitor alone, resistance developed. So then we would add the MEK inhibitors such as cobimetinib, trametinib. And then now we also have palbociclib, abemaciclib, and ribociclib, and triaciclib. But at the moment, those drugs are not actively being used, but they're being researched at the moment in melanoma. And I'll show you there's more drugs at the moment being investigated. So our PD-1 inhibitors would be the pembrolizumab, the nivolumab, and the avelumab. There are others available, like the atezolizumab and durvalumab. Okay, so what do is they stop inhibition of T cell proliferation, okay, and they stop inhibition of the NK function of the cell. And then the PD-1 attaches to the major histocompatibility antigen of the malignant melanoma cell, and it stops the stromal cells mediated malignant melanoma cell growth. That's basics. I don't want to bore you with very complicated processes. And now we're going to go to a very important topic, and it's just always remember, if you have a patient on immunotherapy, you need to watch them like a hawk, because as immunotherapy can cause a multitude of side effects. Okay, so most importantly, you need to watch out for uveitis in the eye, conjunctivitis, scleritis, episcleritis, blepharitis, retinitis. Endocrine wise, you need to look for hypoparathyroidism, and pembrolizumab is one that is known to cause hypothyroidism. That's why when the patient's on the drug at every visit, you do a thyroid function and you watch them. I've had a few patients while they're on pembrolizumab, they become hypothyroid, they develop hypothyroidism and then require altroxin supplementation. But other endocrine issues they can develop is adrenal insufficiency, so you need to watch out for Addison's, and they can get diabetes. They can get hepatitis. You've got to do a full liver function at every visit, and you need to watch the kidneys because they get a nephritis. And then, like our gentleman in the case study, he had a respiratory issue. He developed pneumonitis and pleuritis from the ipilimumab, and you can also get sarcoid-like granulomatosis. And these drugs can affect the heart, causing a myocarditis, a pericarditis, a vasculitis. And as I said, the skin reactions can be debilitating and you need to hold off the drug. They are rashes, multiple pruritus, psoriasis, vitiligo, address syndrome, and even Stevens-Johnson. And then neurologic, they do get neuropathies, they do get Guillain-Barré, even though Guillain-Barré is one of the rarest side effects. They do get myelopathy, they do get meningitis and encephalitis, and even myasthenia. And hematological system, they do get hemolytic anemia, so you need to watch your LDH and do your blood smear and follow your monitor, your full blood count to check for neutropenia, and they can get arthritis and dermatomyositis. So if a patient were to come in with one of these side effects, for example, pneumonitis, which is one of the most common, and a colitis, which is another one of the most common side effects, what would you do? You stop the offending agent. That's the most important thing. All right. And then with immunotherapy for colitis, you don't give them loperamide. That would cause a perforation. You give high-dose steroids. For the pneumonitis, a high-dose steroids. In certain cases, for the colitis, if it's not improving, you have infliximab you can give, and they respond really well to that. But immunotherapy side effects are not a joke. Multiple times patients I've seen on studies, they'll have a grade 4 pneumonitis, and then they need to be put in ICU, and then they get a ALT and AST grade 4 injury, and then you can't put them on the drug again. You don't want to risk it. Whereas if it's a grade 3, you can put them on their high-dose steroids, and if they improve, you can reintroduce the drug. So it's important to remember in the overall picture, when do these side effects come? And it's important, so it's normally between week 3 to between week 14 that you get the majority of side effects, but you just need to know the hypophysitis can happen from after week 6, around week 7, and it continues until even when they have finished their immunotherapy treatment. That's why whenever they come, you ask them about their endocrine symptoms, and you always do a thyroid function and you check your endocrine panel. Very important. I once had a patient, he came in, he was looking very hypothyroid faces. He had put on a lot of weight. He had cold intolerance, and he had the typical myxedema. And the thing is, I had seen in his file, he was already on euthyrox. And I asked him, are you taking your euthyrox? He said, no, I stopped it. He was very slow as well, and his reflexes were slow. So you've got to emphasize to the patient that, these are the side effects, and we've got to watch them, and you've got to take your meds, because if he stopped taking his altroxin, it could have been catastrophic. All right, so with immune-related toxicities, the first thing is you want to prevent them, okay? And that's why when you have a patient and you're giving a PD-1 inhibitor or a CTLA-4 inhibitor, just anticipate what might happen in the back of your head, and then know what to look for. So when your patient sits in front of you, know what to ask and know what to look for on the bloods and clinically. And then if you pick up something, you stop the offending drug and you start treatment with either steroids, immunosuppression, and if need be, for example, if it's a pneumonitis, get the intensivists involved, get the pulmonologists involved. If it's a colitis, get the gastroenterologists involved. All right. So our approved therapies from melanoma. So in 1975, we had DTIC, and DTIC is still around. But I mean, since 2011 until 2020, look at it, all the drugs that have become available to treat adjuvant stage 2 and 3 melanoma, as well as metastatic melanoma. I think we've come a long way since 1975, where we only had DTIC. And moving forward, this year at ESMO a few weeks ago, there was an article on advances in non-cutaneous melanoma, and as well as one on the heterogeneity to the limitation of precision oncology in melanoma. And they were looking at why is it some of our patients have a complete response and have a complete remission for 7, 12 years, whereas others, they have a partial response or or a complete response, but it's not long lasting. And that's what our scientists are trying to work out. And in the pipeline, research-wise, these are the drugs in the black boxes that are currently being used, and the ones with codes are the ones that are still being researched, and hopefully soon we'll have more trials and more drugs available to treat this deadly disease. In closing, I just wanted to say, that's why it's important to ask your oncology unit, what clinical trials do you have? Because we will be shortly having one for malignant melanoma. And we don't have, the only thing we have in the state sector for melanoma is DTIC, and the outcome of using DTIC is minimal. So it's like, at least we have something we can offer the patients who meet the inclusion criteria an opportunity. And not only for melanoma, we have trials in lung cancer, breast cancer, myeloma. So just always, when one of you guys are rotating in oncology, just ask the fellow and your consultant, what trials do you have available? And just let it be known in the pulmonology circuit, in the derm circuit, they've got something for lung. And then you get the patients to us earlier, and we're actually able to help them better. And then I asked the question, has South Africa has been left behind in precision oncology? And the answer to that is yes and no. We have the knowledge, but in the public sector, we don't have access to any of these drugs. We have access to DTIC, which was available in 1975. So I'm basically saying for melanoma, we're offering patients now in 2022 what we had in 1975, unless we can get them on a clinical trial. In the private sector, yes, these drugs are available. And the thing is, the patient has to have a very good medical aid, because one dose of pembrolizumab is 90,000 Rand, and even the top tier medical aids, they won't pay for all of that pembrolizumab. There's going to be a 20% co-payment, and a 20% co-payment at every cycle for a year. It's a big chunk of money out of the patient's pocket. And then, you know, I've seen patients where they land up selling their cars, they land up selling their houses, they land up selling their holiday houses just so they can buy their immunotherapy. And as doctors and internists, it's important to be our patients' advocates. So that's why I say, just keep your eyes open and your ears open. And if you have a malignant patient with a malignancy, but think about it, does oncology have a trial, and refer the patient to us. All right. Whether our government will be able to give us access to CTLA-4 inhibitors, PD-L1 inhibitors, and BRAF and MEK inhibitors, I don't know. They currently are available in Australia, in the state sector. Europe provides it. And I think we, as a Woolways, one of the few that doesn't. I mean, we have a lot of other medical issues in South Africa that we're trying to tackle. But cost implication internationally is becoming a problem, and the pharma companies are starting to realize it. I just hope something gets done about it soon. Any questions?